So my question to you, Dr. Aanchal, is explain unscheduled bleeding on menopausal hormone therapy. What is unscheduled bleeding?
Bleeding occurring within 6 months of starting of HRT or within 3 months of starting of changing the doses or changing the preparation.
Is common and is not considered.
Yes.
And after that, it would be, so any bleeding occurring after the 6 months of initiating HRT or within or after the 3 months of change of preparation. So our patient had a bleeding 8 months later. So is it unscheduled?
It is unscheduled.
It is unscheduled. What is the percentage? How many people are affected?
For continuous combined HRT, it is 41%, and for sequential, it is 38%.
So it is a leading cause of repeat consultation who are on menopausal hormone therapy, and some may like to stop that therapy. So Dr. Jyotsana is not here. Anyone can take that step-to-step clinical assessment and unscheduled bleeding on HRT. What would be your call? Dr. Jyotsana, please come. Please join. Can we have a chair? So Dr. Jyotsana, your question is here. So how would you do a clinical assessment of unscheduled bleeding on HRT?
So
8 months. 8 months MHT.
And she is having. First of all, I would take a proper history, ma'am. That what is the reason? I mean, what is the bleeding pattern? Is it just a spotting, or is it just a withdrawal bleeding, or if it is a unscheduled bleeding with heavy clots, or it's a prolonged bleeding? Then I will ask for her associated symptoms, like is she having pelvic pain or dyspareunia, any vaginal discharge, is there any history of itching or vulvovaginal symptoms? Then I will ask about her HRT, the detailed history of HRT, whether she is sticking to her HRT protocol or not. Is she taking it properly? Is there any history of missed pills? Is she taking any phytoestrogens also, like, or any drug history, like if she's taking any anti-epileptics or antifungal? All these things I'll inquire, and then I will assess her endometrial cancer risk factors. So for that, I will ask the proper history. If she's a, BMI, what is her BMI?
BMI is 40.
So if it means that she has a major risk factor, because BMI more than 40, and yes.
So
BMI
proper
more than
history
40.
taking and
Yeah.
proper history taking about the bleeding which has occurred,
Yeah.
and examination is what is the key. And other causes of the bleeding has to be ruled out. So Dr. Kanchan, can you tell us that apart from the HRT, are there any risk factors
Yes.
independent of HRT?
Yes, there are major and minor risk factors. The major risk factor is BMI. BMI more than 40 is a major risk factor. Then second one is the genetic predisposition. And if she is taking sequential therapy for more than 5 years, if started after 45 years, that is another risk factor. And another risk factor is if the progesterone is given for less number of days, like norethistron given for less than 10 days and micronized for less than 12 days. That is another risk factor for this. If the minor risk factors are BMI between 30 to 39, then history of PCOD, history of diabetes mellitus, and very important or very, you can say, important risk factor is that if she has put in LNG IUS and if it is expired, that needs to be looked for because she will lose the protection of
Because she thinks that she is progesterone covered, and
yeah,
then she becomes a risk to other types of diseases. So Dr. Chetna, our patient has bleeding which has occurred 8 months after continuous HRT. So what she is asking, is it normal or not? This. So can you explain it to her?
As we discussed, that this unscheduled bleeding, it's normal only within 6 months when you have started, or when you are changing it, it's like 3 months within changing it to a new type of or route of HRT. So definitely this is not normal.
It's not normal.
And she will need evaluation. So as we said, proper history taking regarding other symptoms, the type of HRT she is taking, and her risks for all these things, major and minor risk factors. So we will take that.
So after 6
So-
months, she should become bleed free. And in case of combined, and in case of sequential, you should have light bleeding of the progesterone withdrawal. Dr. Pratibha, how will we triage the unscheduled bleeding? Any further investigations?
Madam, so after we have done all these and looked into factors for risk factors for the endometrial cancers, if the risk factors are less than 3, in those cases we can do conservative management. And if they are more than 3 or 1 major risk factors there, we have to go for urgent transvaginal sonography. If the patient is on sequential HRT and endometrium is more than 7 mm and on continuous combined and it is less than more than 4 mm, then we have to keep the patient for suspicion of cancer and we have to go in that pathway. And in cases where these things are not being met, we can adjust the dosage of HRT, especially the progesterone part, and we can keep the patient under monitoring, madam.
So we see for
optimizing
the,
HRTs.
yes, we see for the major and minor risk factors, and we decide whether she can have a conservative change or she can have to be managed. Dr. Suma, any role of ultrasound? TVS? Any endometrial measurements? You will put it as cutoff?
Yes, as Dr. Pratibha already said, that endometrial, a patient who is on continuous therapy in endometrial thickness of 7 mm, less than equal to 7, more than 7 mm
In sequential.
in sequential. And the one who is on continuous therapy in her endometrial thickness of more than 4 mm is the cutoff for
further tests. Further test. And before that, you can have a conservative. Any other thing when the endometrium is not visible because of fibroids or polyp, when then also you have to see and you have to optimize in that case. Any recommendation for biopsy? Any gold standard? Dr. Sheela?
Like we've already said, that if she's on continuous, then less than 4 millimeters, or if she's on sequential, then less than 7
Okay.
thickness.
Okay.
Have to do, and the ideal would be a hysteroscopic biopsy.
So it would be a gold standard would be a hysteroscopic biopsy. So in any condition where the endometrial thickness is more than 4 millimeter in combined and more than 7 in sequential, apart from that, even if she is asymptomatic, but if you cannot assess the endometrium, then also because of fibroids, or she is asymptomatic but her endometrium comes to be 10, then also. And then if she is normal endometrial thickness but she has heavy bleeding, then also you do a biopsy.
She's not, if I think that she's non-compliant.
Yes, then also you should do a biopsy. And if you have done a blind endometrial biopsy, should we go for hysteroscopic?
If possible, yes.
Yes, if possible, yes. Hysteroscopic biopsy or targeted biopsy would be very much a gold standard and advised. So how would you manage this? How would you optimize? And if the BMI is 40, so what would you do?
In this case, we will investigate her. We will do her USG, and if the endometrium thickness is more, then we have to do the hysteroscopy.
So some basic rules would be there.
Check
And in this case, you can put her on LNG because she was on transdermal. You can put her on LNG. And what about fibroids if she had?
we had fibroid. If it is less than 3 centimeter, we can go for LNG IUS. If it is obstructing the cavity, we can go for some mucosal fibroid resection also.
And you ask her for
Okay,
lifestyle
for-
to decrease the BMI. Weight management has to be done. So we move on to the next case.
So this is a case, 56 years. She's requesting for MHT for anti-aging. Menopausal status, postmenopausal 10 years. And medical history is nil significant, no chronic conditions. So she's already 10 years ago, she attained menopause at age of 46. Clinically now, currently, she doesn't have any hot flushes, night sweats, sleep disturbance, or mood changes. No significant medical history, family history also nil significant, and all the investigations are within normal limit. Next. Next slide, please. So can MHT be started only for anti-aging purpose? Dr. Sheela Jain?
We know that MHT is not an indication for anti-aging, especially at this age also. But for this patient, I would like to take a good history. And because, many times these patients, though she's coming with this complaint that she wants anti-aging. Maybe she's got some other complaint like genitourinary syndrome. So they do not directly come with that symptom. So this I would do, take a good history, examine her, and then she needs a counseling.
Yeah.
I need to tell her that this is not an indication as such.
Yeah,
If she has some
because
other
she thinks that
indication.
MHT can improve her skin regeneration, energy enhancement, and dementia prevention, but it is not approved. Yeah, next slide, please. So, what is the window of opportunity for MHT?
Window of opportunity is the time when if we start MHT, we can give maximum benefit to the patient. So it is a period of 10 years from the start of menopause when if MHT is started, it gives maximum benefit.
So, all the benefits she will get if it is done in the period of. So, she is almost, I mean, she is going to finish that. So, the different guidelines says that risk benefit shifts unfavorably when MHT started after 10 years postmenopause, and she is outer age or just beyond the window. So, there is no question of starting for anti-aging. Okay, next. How would you assess her clinically?
Initially, we will take complete history of the patient and what does she mean by anti-aging, whether she is asking for libido or for sleep disturbances or anything else. And then complete medical histories, drug history, family history, and then examination, proper full examination, BMI, weight.
So,
blood
we have
pressure
an
measurement.
opportunity to assess her clinically, whether
completely.
she has any, and investigate her. And as Dr. Sheela mentioned, that she may be having
symptoms.
genitourinary syndrome. So we may have to take that. And for that, I think we may give her. But that is also usually we apply, I mean, ask them to use something local. Next. So what are the specific risks after 10 years? Yes, Dr. Aanchal?
Venous thromboembolism risk is increased, CVD risk is increased, and but all this risk are more with oral estrogens rather than transdermal estrogens. And breast carcinoma risk is increased, but earlier it was because of MPA and norepinephrine. Now we mostly use micronized progesterone and dydrogesterone, so risk is less. And we have already discussed is lifestyle risks are more for breast carcinoma rather than our MHT per se.
Okay, so for symptomatic women starting MHT within the window, the benefits clearly outweigh the risk. And for an asymptomatic woman, purely there is no symptom benefit to offer the increased cardiovascular and thromboembolism. So what evidence-based alternatives can you offer her?
Important to take her history, actually what she actually means by anti-aging, and then depending on that. So you have to counsel her regarding lifestyle changes. You have to ask about her sleep patterns, then sleep hygiene, if she means insomnia by that, and depending on her other factors like her risk of osteoporosis or family history of osteoporosis, and then her cardiovascular risk. We have to guide her regarding lifestyle changes, and then if she has hypertension, then again use of antihypertensive, and we can always revise at each visit her cardiovascular risk and all. So if she has issues with her skin and cosmetics, again we can refer her to even dermatologist or a local, whatever she can use. And regarding vaginal, sexual health also, if she has reduced libido, we can always prescribe her even after 10 years that local vaginal estrogens and non-hormonal mostly I'm talking about.
So I think we had a session in the morning, so all these things can be handled. And after thorough assessment, we find that she has significant symptoms. Then if hidden symptoms are found, mostly you will not get hot flushes at that period of time, because it is usually, mainly it is the,
And yes, she must have hot flushes. But if she really has hot flushes or night disturbances, sleep disturbances, night sweats, severe disturbances of mood, cognition, and genitourinary symptoms, or severe joint pain, and on DEXA scan, if she has osteoporosis, and if she really has symptoms, then we should consider her MHT. And at this age, preferably, it should be transdermal estradiol.
and a very low dose.
Very
Even in
low.
transdermal also,
Very
for
low.
everything, whatever, and a short period of time. We may not have to. Yes. Next. So complete line of management, Kanchan.
Yes. If she remains asymptomatic, actually, the role of counseling is very, very important. because they see the advertisement that MHT reverses your aging, or if you want to remain young, take MHT. So you should not dismiss these statements, but we have to counsel her for what she wants anti-aging. What is her concept of anti-aging? That is very important. And this is very good window of opportunity for us to do a DEXA, mammography, and pap smear if not done, because that time she will be very compliant. And if all the issues should be addressed individually. If she has bone problems, if she is concerned about that, start calcium, vitamin D. If she has skin problems, start sunscreen, all those things.
So you
And-
have an opportunity to tell her that
Right. So counseling
anti-aging
is
does
important.
not mean only the
Yes,
skin or
yes.
anything. There are so many other
Other-
aspects.
Yes.
In fact, bones, heart,
even ophthalmic.
dyslipidemia,
Yes,
ophthalmic,
ophthalmic.
statins, everything will play a role. So she says that it protects against breast cancer. Is that true?
What?
Protection against breast cancer.
Cancer.
Patient is saying.
No, no, no.
Yeah.
We have to counsel them about it.
So always use absolute risk numbers, not relative. Compared to lifestyle risk, she already accepts. Never use alarming language. The goal is informed, unalarmed decision making, and not avoidance through fear. So estrogen only has more favorable breast profile, but applies only to women without a uterus. And combined MHT, there is a small increased risk, approximately less than 1 extra per 1,000 women per year. And it depends again on type of progesterone. That is, we already discussed that. Okay, next. And my friend told me MHT is the best thing for bones. Should I take it? I think we already explained about it, that at that age, no MHT for bone protection. Because I want her to finish one more case. Okay. So after full counseling, she instead she wants, what do you do? I think we discussed, right? That we can start her on a minimal dose. Yeah, lowest dose. Next.
Thank you, ma'am. So we move on to the fourth case that she is a case 42 years and she presents with cessation of menses for the 12 years and she is an IT professional with a chronic smoking habit. Her menstrual history was regular, but she had a strong family history that the mother experienced natural menopause at 44 and her aunt also experienced menopause at 42. She had a cyclical history with regular periods. She has now symptoms of somatic, psychological, and urogenital symptoms as well. So, Dr. Kanchan, what should be the condition called? What would be the causes of this condition?
Yes. Actually, menopause, there are three this thing. Premature is below 40. And 40 to 41 is the early menopause. 41 to 45, you say, it's early menopause. And after 45 is, of course, natural menopause. So
And there is
yes.
a condition called POI as well.
Premature ovarian insufficiency, where there is irregular cycles, amenorrhea.
Any causes for these conditions?
Causes, for premature menopause, you're asking, right? Yes.
For any of these,
Yeah.
early menopause,
If,
premature menopause.
Basic iatrogenic causes are surgery, radiotherapy, or chemotherapy. Then autoimmune diseases, genetic, these are the main. And if not found, and then you can say iatrogenic POI.
So you rule out that whether she had some
Smoking,
surgery.
Lifestyle factors like smoking can lead to early.
Yes, smoking is in an individual factor, and effect of smoking is different from what it causes the lung changes. It is the polycyclic hydrocarbons which are contained in the smoke which cause it. And first is important, rule out history, that is surgical history, then the chromosomal or genetic, and then you autoimmune diseases. Also have the adrenals, the thyroid, they all have a role in the diagnosis. So any investigation should be performed in these cases. Dr. Suma?
She's having amenorrhea from last 12 months. We never know that in between she might have got pregnant. So beta HCG should be done. By history and otherwise also we have to undergo take thyroid profile. Apart from that, from history itself, we have to ask about autoimmune diseases. Any features are there, then we have to go for autoimmune panel as well. We may have to go for USG.
But role of FSH in this case, do you recommend FSH?
Yes, ma'am.
So in the madam's lecture, you saw that the FSH doesn't carry a role where there are clinical symptoms of menopause. But when there is an early menopause, you advise her FSH. What should be the level?
40.
More than
40
40
on 2 occasions.
of 2 occasions.
12.
More than 40.
And that is not
4
time
weeks
bound.
apart.
That is not time bound. That is it. You do a bone DEXA as well, and you rule out the history of hormone therapy, whether she's taking, and surgery. So, Dr. Chetna, would you like to give her hormone or no? Yes or no?
Yes, definitely.
Why?
Because the protection, I mean, the bone health protection and cardiovascular protection, which is there at normal age of menopause, it's lost. So definitely, I mean, she needs to have a hormone therapy to protect her bones and to have a good sexual life and her cardiovascular risk.
So it would be personalized, individualized therapy, and it would be on the patient's preference, her contraceptive needs as well, whether she has some comorbidities. But yes, hypoestrogenemia has been for long time, so she will require hormones. So it is a yes. And there are various preparations you can use from ultra low dose to high dose, which would be, and it can be individualized with the dose, regime, and duration. So if she opts not to take, she says, I don't want to take hormone therapy. Dr. Suma.
We have to counsel her, but because the patient is complaining of severe symptoms, so we have to counsel her that hormonal therapy is the best mode of management for her. And then we have to start on her on hormone therapy. If she is not, we advise her regarding different modes of treatment. The best, maybe if she is not compliant with oral therapy, we can go for transdermal therapy.
But she should take, because the effect on the bone and effect on the cardiovascular is for a prolonged time. So it is advised. You have to counsel that there are sequential regimes and transdermal regimes as well. So her next concern is that, okay, I'll take HRT, but how long I have to take?
In the natural age of menopause.
So she will have to take as much Indian average to 47 years at least. And with the option to use oral contraceptive, she has. Okay. So she's still concerned. She's still concerned that what are the risks of hormone therapy? Are there any cancers? Is there, Dr. Jyotsana?
Per se with MHT, the chances of endometrial cancers are there only if she doesn't take unopposed, if she takes unopposed estrogen. So we should advise her to take progesterone in addition to estrogen. Then chances of endometrial cancers are not there. And if she asks for breast cancer, then it is just only one extra case per 1,000 per year, and that is actually equivalent to if we compare it with the women of same age, it is not increased. So only factor is unopposed systemic estrogen therapy. Then she can have the risk of endometrial cancer. Otherwise, there is no per se increased.
Okay. And if the uterus is removed, moreover, then she can.
Then she can take only
Okay.
estrogen.
And if she has been operated for early endometrial cancer, grade, very low grade,
So
she
ma'am,
can have.
if she has low grade, then she can take MHT. But if it was an advanced cancer, then she should not.
She should not take MHT. Okay. She wants to conceive. Dr. Aanchal, what is she's desirous of pregnancy?
She can have spontaneous cycle, also spontaneous ovulation. She can get pregnant, as we discussed, because we were doing beta SCG, because she would have got pregnant. But ovulation induction or IVF is not recommended for her.
Oocyte donation?
Donation can be done.
Fertility preservation and counseling at the time we were doing it?
Yes, yes. We
Ovarian
do,
okay.
we should do that. If there is a history, if there is a high risk factor for premature ovarian insufficiency, then we should definitely do counseling for fertility.
Thank you so much. Yes, we were in time.